Okay, good afternoon, everyone. My name's Shane Parker, and I'm going to do a webinar here today for you guys for basically to talk about the reason for more nurses and lower costs, better patient care, and better financial outcomes for the healthcare organization. As we get started here, if you all have any questions, please go ahead and type them into the question box there in your GoToWebinar, and we'll address questions in the end. But our main focus today is really to discuss the financial impact of hiring more nurses and the impact of the outcomes of patient care when the request for FTEs is warranted, additional FTEs. And we'll also talk about a few solutions to this problem that I'm quite certain all of you face on a daily basis. So just a little bit about me. My name's Shane Parker. I'm the Chief Nursing Officer and co-founder of ShiftWizard. We're based here in Raleigh, North Carolina. And to all the folks out there that are in the Southeast, buckle up. Looks like there's going to be a pretty big hurricane coming our way. So I hope everybody's safe, and I'm sure all of those hospitals have their contingency plans put in place. And it's going to be a busy few days for everybody. But my background, I was a bedside nurse for about 14 to 15 years, mostly in emergency rooms from small community to level 1 trauma centers. I did that for about 10 years, and then I transferred over into critical care transport and invasive cardiology. I went to ECU in Greenville, North Carolina, and then got my associate's degree in nursing from Sandhills. And I also sit on the advisory board for the ANA for workforce management. So on the agenda today, as you can see, we're going to discuss strategic staffing, what the latest data is showing us, fixing the problem, and the case for more, meaning more nurses. So let's start with strategic staffing. So how do you keep patients, employees, and your CFO happy? Optimal staffing has been proven to reduce costs. Optimal staffing reduces overtime. Optimal staffing reduces turnover. It leads to lower odds of being penalized under the ACA Act. And optimal staffing obviously increases profitability. Hospitals with a higher nurse staffing had 25% lower odds of being penalized compared to otherwise similar hospitals with lower staffing, which I thought was an interesting stat. But there's always a classic struggle between nurse leaders and finance. I think we've all dealt with it. Obviously, nurse leaders want more resources and the ability to provide better patient care, or excellent patient care for that matter. And then finance, of course, wants the nurse leaders to stay within budget. But nursing's become difficult lately, especially with turnover and burnout. As nurse leaders, you shouldn't be forced to choose between nurse engagement, patient care, and labor costs. And unfortunately, 50% of nurses working in the United States today have considered leaving the field. And that's a big number. I speak with a lot of nurse leaders throughout the year, and what I hear is that patient safety and patient outcomes are their #1 concern. And as a nurse leader, your focus should be on strategic staffing that leads to excellent patient care, improves staff morale, and focuses on staff recognition and retention. So why do nurses leave? There's the top 10 reasons are listed here. The first 3 are uncontrollable. So when you look at the top 3, you've got personal reasons, you've got relocation, and you have retirement. These are out of control of your organization and you as a manager or a leader. But when you get to number 4 and number 5, you can see that workload and staffing ratios and employee schedules, work schedules, are controllable. Career advancement and salary, those may be controllable. Career advancement, for example, if you have a clinical ladder program in your organization, and then salary, if your particular organization is in the has the opportunity to look at competing hospitals maybe and make some adjustments with salary. But then number 8 and 9 are controllable as well. So education, I know a lot of hospitals have an education reimbursement program. And then the opportunity for expedited management positions. And then number 10, excuse me, is which is an uncontrollable factor, is commute and location. So overtime is not the answer. Unfortunately, excessive overtime used to resolve vacancies increases stress, burnout, and turnover, while negatively impacting the cost and quality of patient care. And research reveals that a direct connection between nurse staffing and every single one of the outcomes listed below has the opportunity to significantly impact the hospital financially, while at the same time delivering excellent patient care. No, I'm not going to read through all of these 20 or so bullet points, but every one of these can not only impact an organization's financial status, but they can also save a life or improve the quality of somebody's life, which is the ultimate goal and the reason that we all became nurses. So permanent nurses, just a couple stats here. Permanent nurses work an average of 9 overtime hours per week, while traveling nurses work an average of 7 overtime hours per week. And nurses working shifts of 10 or more hours were almost 2.5 times as likely to experience burnout and job dissatisfaction. And while overtime is somewhat unavoidable, hospitals should make sure they're fully leveraging flex staff or float pools whenever possible. And while labor costs initially increase with the higher number of experienced nurses, the research shows us that hospitals actually experience significant reduction in overall costs when they increase the number of experienced nurses, which is why retention should always be a top priority of any organization. So what does the latest data show us? When we look at turnover, the average cost of turnover for a bedside RN is $49,000. Excuse me. The average hospital loses about $5.7 million per year to turnover, and each percentage change in nursing turnover will cost the average hospital $337,500, which I thought was an interesting stat. But according to the 2018 National Healthcare Retention and RN Staffing Report, the cost of turnover can have a profound impact on the already diminishing hospital margin and needs to be closely monitored. And today we're seeing hospital turnover at its highest. Right now, the average is about 18.2%, which is the highest in over a decade. The average turnover rate for nurses is 16.8%. That's 2% higher than just the year before. And the current average vacancy rate for nurses is 8.2%, which is about 0.1% higher than the year before. And why is this? We've got this leaky bucket syndrome. We've got baby boomers that are retiring. We've got 27% of baby boomer nurses say they'll retire in 2018, and another 73% of those will retire in 3 years or less. And then you have the millennials. 24% of millennial new hires left within a year. 53% of millennial turnovers have less than 2 years experience, and 19% of first-year millennials turned over in 2017. Those are big numbers. So when we look at productivity and overtime, what does the data tell us? Well, it tells us that each additional patient per nurse was associated with a 7% increase in likelihood of patients dying within 30 days of admission and a 7% increase in failure to rescue. Those are very concerning numbers, not only as a nurse, but also as a nurse who has family that may go into the hospital. Those are very concerning numbers. But a higher proportion of nurse to patient ratios was also associated with lower mortality rates, lower rates of adverse hospital events, including pressure ulcers, UTIs and falls, and lower rates of other adverse patient outcomes. So compared to nurses working 8 to 9 hour shifts, nurses working shifts of 13 hours or more are 270% more likely to experience burnout, 240% more likely to be dissatisfied in their jobs, and 260% are more likely to leave their job in the next year than nurses that work 8 to 9 hours. So management techniques. You want to utilize technology to easily identify when employees are in overtime or are going to be in overtime and make proactive changes. And you're going to want to monitor productivity in real time. Use technology to help identify departments and hospitals that may be overproductive, and then find help for those departments. And without proper technology in place, it's nearly impossible to monitor these situations and make proactive changes before overtime, burnout, dissatisfaction, and turnover occur. So staffing ratios, what does the data tell us? Well, it tells us that higher RN staffing is associated with decreased risk of hospital-related mortality, hospital-acquired pneumonia, and other adverse patient outcomes. And overall, the majority of the literature on nurse staffing and patient outcomes suggests that greater levels of nurses lead to better patient outcomes. And higher levels of nurse RNs result in increased operating costs, but there are significant effects of nurse staffing on profit margins, which questions why hospital management practices of reducing nurse staffing during times of financial hardship. In hospitals with greater nursing staff levels, resulted in cost savings due to reductions in hospital-acquired infections, shorter lengths of stay, and improved productivity. So how do we fix the problem? There's a few solutions, but the first thing you've got to do is take an enterprise-wide approach to staffing. I think, in my opinion, that supplemental staffing pools are probably the best way to fix these problems, which means hire more nurses. You can also look at productivity and overtime. You can look at forecasted staffing, and you obviously have to have technology in place that will help pull all of this together. So we're going to talk a little bit about staffing pools here today, and we're going to give you a few stats and then give you some guidelines on how to set up a staffing pool, supplemental staffing pool, and what you should expect as your outcomes and what your goals should be. So an interesting stat is that hospitals that implement resource teams as an overall staffing management plan typically have a 2 to 5% typically save 2 to 5% of total nursing labor costs, which with benefits are the largest components of hospital labor costs. And then the Labor Management Institute showed that overtime and adverse patient outcomes, such as medication errors and patient falls, were lower when unit core staffing provided at least 85% of the care delivery hours, and that up to 15% of an organization's nursing staff needs could be safely met by a flexible staffing source, such as per diem, casual, staff from other units, float pool, or as a last resort, agency and travelers. But what's interesting is that only about 40% of hospitals use resource teams, and those that do frequently do not use them effectively. So the goals of building a supplemental staffing pool. One of the biggest goals, of course, is to decrease overtime. You're also going to want to eliminate high levels of individual overtime. As we know, there are staff out there that depend on overtime as part of their salary, but we can't let those staff abuse those overtime hours and exceed what the organization's policy is. We're going to want to eliminate agency and travel nurses, and we're going to want to identify scheduling policies and standardizations, such as requiring your core staff to work every third weekend. We all know nurses don't want to float. Supplemental staff don't like to be canceled. So outcomes would be to reduce the amount of floating and cancellation for your core staff, for your supplemental staff to experience minimum cancellations, for your supplemental staffing pool to provide the flexibility for expansion and contraction based on census fluctuations and both expected and unexpected staffing needs. And make sure that productivity and overtime are within expected ranges. Staffing and scheduling positively contributes to patient care and satisfaction, staff morale, and retention and recruitment. So developing an internal staffing pool to empower your nurses to do self-directed floating. So one of the things you're going to want to look at is recruiting and hiring PRNs from other nearby organizations, for example, who can commit to, say, 2 8-hour shifts or 2 12-hour shifts per month. You're going to want to implement a technology that allows your supplemental staffing pool the ability to view open shifts in the future from home or from a mobile device, and they'll want to be able to view those shifts across the enterprise. You're going to want to better utilize your part-time employees, so you're going to want to cross-train those employees to multiple departments. And then one of the hospitals that we work with instituted a program called Happy to Help. This program offers a small differential if their staff volunteer to float to another department, and they've seen great success in that. So with building out a supplemental staffing pool, you've got to identify your resources. So you have to identify your unit core and your contingent staffing size, both current and future state of your unit. And you've also got to identify your supplemental staffing pool core and the contingent staffing size of the pool itself. And so when we look at defining those resources, your core staff, these are resources that hold a full-time or part-time committed position and are based in a specific unit. Your contingency staff are resources that would include your supplemental staffing pool with or without FTE commitments, all staffing pool above their FTE or in overtime, and PRN, which can be unit-based or supplemental staffing, and any external agency or travelers. So when you look at the percentage of resources that should be allocated to your specific unit to cover your unit, 80 to 90% of coverage should be your core staff, and these are committed unit-based resources. These are your full and part-time staff, so basically your unit's FTEs. 3 to 6% should be per diem staff. These are also committed and unit-based, and these are the resources that are initially added to your schedules to fill in for planned time off, such as vacations, education, FMLA. These are your specific units per diem staff. And then 5 to 10% should be your supplemental staffing pool. These are committed and uncommitted, and these are enterprise-wide. These are the staff that are assigned throughout the enterprise to cover your daily and your shift-to-shift schedule changes. And then lastly, you have 2 to 4% of overtime FTEs to finish out covering your department. And you notice that agency and travel are not included in the staffing model, and these resources should always be used as a last resort. So forecasting is another big factor in this staffing model as well. And there's been a lot of talk around predictive analytics and the efficacy of a solution that provides predictive analytics and forecasting. In my opinion, in the least, you have to have some sort of technology to forecast ADT information, even if it's only short term, even if it's only 12 to 48 hours, because it can be extremely beneficial in helping to mitigate your staffing shortages. It also allows for more accurate coverage while providing fewer instances of over and understaffing, and allows for better nurse to patient assignments, leading to equitable distribution of workloads. And then technology, of course. You need to have the next generation technology that provides quick, intuitive access to all open shifts in an organization across the enterprise, with the ability to easily float, flex up, or flex down when appropriate. And you've got to implement a technology that allows for the management of your supplemental staffing pool with full transparency across the enterprise. Because as I said before, it's nearly impossible to effectively manage this type of staffing model without the proper technology in place. So the case for more. So when we look at the case for more, there's obviously a huge impact on patient care and ACA reimbursement when we talk about staffing. Under the Patient Protection and ACA Act, factors that affect hospital reimbursement, which you guys are all probably very familiar with, are 30-day readmission rates for acute MI, heart failure, and pneumonia, 30-day mortality rates for acute MI, heart failure, and pneumonia, and then patient satisfaction scores as measured by HCAHPS satisfaction surveys. So just a few points on the impact of patient care and ACA reimbursement, which is very well documented. Higher non-overtime staffing levels decrease the risk of readmissions, while higher overtime staffing levels increase the risk of patients revisiting the emergency department recently after discharge. Mortality risk rates decreased by 9% for ICU patients and 16% for surgery patients, with the increase of only 1 FTE per patient day. And then only 1 additional nurse hour per day with the patient was associated with a 1.98% decrease in death rate. That's big. One nurse hour per day, and you can increase the patient death rate by 1.98%. And then statistical models show that when nursing units are understaffed, the additional cost associated with those patients who develop complications are greater than the labor savings due to understaffing. And while immediate personnel costs are less with short staffing, the long-term costs were higher because patients with complications often stay longer in the hospital, require other expensive treatments, or end up being readmissions. So we're going to move into the question section. I want to open up the floor for questions, and then also want to let everyone know that we're working on an ebook that will be out shortly, and we encourage you to reach out to us and request for a copy of that ebook. We'll be happy to share it, and we'll be posting this webinar as well on our website. So if you have some colleagues that happen to have missed it, or you want a copy of it, please feel free to share the link once we have it. So let's see here as far as questions. Okay, yep, we got one from Sue. Yes, we will be able to share the slides. We'll be happy to share those with you. And then how can I relate this information to my CFO? And this is a big thing. Obviously, as I said in the beginning, there's always kind of this battle between nurse leadership and CFO. You know, for me, I would approach it in terms of patient care and patient satisfaction and HCAP scores. There's a lot of data out here, and once you're able to get the webinar itself, the slide deck here, I've cited everything that I've talked about today within this webinar, so it will help you hopefully bring some ammunition to your CFO. And there's other issues outside of just the enterprise as well. You also see some departments who run very high productivity. They're working a lot of overtime, and you know, you're asking the CFO for an additional FTE, and they're pushing back. And so you've got to have your data in place, and you've got to have, you know, hopefully some type of technology that will show your CFO that your staff are overproductive, that they're on the brink of burnout and turnover, and that you need that extra FTE, which is gonna cost you less than having an overtime employee pick up those shifts. And yeah, I see, Ali, you posted here that he always wants to reduce labor costs, and yeah, again, that's always a big argument. But I think, you know, to arm yourself with some good data and some good literature is important when you take this information to the CFO. So how long does it take to implement a float pool if one is not already implemented, and what's involved? It takes time. It's not something that happens overnight. The biggest piece of it is starting to develop, you know, some policies and procedures around developing that float pool, and then also figuring out your goals and your outcomes. And then also you've got to look from an enterprise perspective to see, you know, exactly how many float pool or supplemental pool, if you will, whatever you want to call it, how many staff you're going to need to fill in all of those holes. Not only are you going to have to look at it enterprise-wide, but you're going to have to look into each department, and each department's going to need to come up with a plan in terms of how many hours and how many open shifts they have each week or each month or each scheduling period, whatever it may be, and how many staff you're going to require to fill all of those holes. And then Patrick asks, where can I get a list of the cited references? They'll be included in the slide deck here. They're actually on the last couple pages. I've got all of them cited. There's a lot of really good information out there. I've spent several weeks going through and combing through all of this information, and I really, the things I cited were probably maybe 10% of what I found out there in terms of articles for supporting evidence. But certainly I've got everything cited here for you, and when we make the slide deck available, which should be in the next day or so, then you'll have access to all of that. And then Robin asks, can you provide more details about the Happy to Help program, and how much was the differential, and how did the program integrate with ShiftWizard? Yeah, so the Happy to Help program was with a large hospital system here in North Carolina. And I mean, I was a bedside nurse for 15 years. I know nurses hate to float. And so what they did was they implemented this program that's called Happy to Help, as I mentioned. I don't remember off the top of my head exactly what their differential was, but I want to say it was somewhere in the $2 to $3 per hour range. And then in terms of how does the program integrate with ShiftWizard, same question from Robin, is whenever this particular organization goes in and floats a nurse with and it becomes a Happy to Help situation, we actually have an icon in our solution that's able to track all of that, which is important because also when you get to do evaluations of employees and you're looking everything that happened in the past year. If you can see that you have a particular employee that has volunteered to float multiple times, that's good to know. That's good to provide employee appreciation and things like that as well. Another question from Terry: how can we help nurses increase engagement in an effort to facilitate such changes? That's a good one. I think, the big thing is helping nurses understand, not that they need help, but in terms of engagement, helping them understand that a staffing program like this, or a happy to help program like this, actually helps decrease the employee's patient load. It decreases decreases frustration, increases satisfaction. I know, again, I keep going back to when I was nursing, but there's nothing more frustrating than to have more patients to take care of than you can really take care of. As we all know as nurses, unfortunately, when that begins to happen, then patient care suffers. And I think we're all in this for patient care. That's the reason we all went to nursing school, is to help people. And so, it may be an approach as to, a program such as this, or a happy to help program, whatever it may be, obviously will increase patient care, will increase patient or staff satisfaction. And the overall strategy, is to have happy patients and happy nurses. We got one more question here. How long does it take to implement the technology associated with supporting enterprise float pools? So for us, for ShiftWizard, whenever we go into a organization and implement ShiftWizard itself, it completely depends on the size of the organization, but we're typically looking at a 12 to 16 week period. And our float pool management module actually kind of looks at some of the things that I spoke about throughout the webinar, where it provides full transparency of open shifts throughout the organization. It provides you with all of your employees, your supplemental staff employees, for example, who have requested to work, and which departments they can work in, and whether they have the right license certifications, and then things like floating employees to other departments as well. If you're looking outside of a supplemental staffing pool, when you have that full enterprise view, and you can see where Department A is short and Department B is overstaffed, is there an opportunity for somebody from Department A to move over to Department B, assuming they have the right qualifications and certifications and all that type of stuff. But the biggest thing is transparency. You've got to have that transparency across the enterprise to be able to make those decisions. Any other questions from anyone? Okay, if there's no other questions, we'll go ahead and wrap this up. If questions come up afterwards, please feel free to reach out to us. We're always happy to help, and as I said, we'll provide a copy of the slide deck as well. And we've got one more question here from Robin. Do you have a float pool model you can share? Yeah, Robin, if you want to reach out to us, we certainly have some examples of hospitals that we've helped with developing float pools. They really do make a big difference. I was kind of surprised when I looked through the data here, and one of my data points was that only about 40% of hospitals utilize a float pool or supplemental staffing pool, and an even smaller number of those use it effectively. But yeah, please feel free to reach out to us. Our contact information is here on the screen, and we'll be happy to get with you and provide some information on float pools. You're welcome. All right. Thank you, everyone. And again, feel free to reach out to us. I appreciate your time today, and enjoy the rest of your afternoon. Thank you.